So I get the honor of introducing Dr. Persell today. A little bit about his background. So we were just talking, I didn't realize, but he grew up in Manhattan, then went to Haverford, which people might not know from around here, but it's a wonderful school in Pennsylvania. Obviously, he was good enough there because he got into Harvard Medical School and then did his residency at Brigham and Women's. And while he was there, I guess he began his interest in health processes and health sciences research because he got his master's in public health. And it was actually, I didn't realize he could do this, but it was on, what was it on? Your master's in public health was on clinical effectiveness, which is really cool. And so he did that, and then he stayed for 2 years in the Harvard system before coming here in 2003. So that's about when I came here, and I more knew Dr. Persell as a guy who attended in the general medicine clinic or on the ward sometimes, which he still does, which is great. And he must have an outsized impact because I remember him from that and didn't realize that was the tip of the iceberg of all the other stuff he does. So since he's been here, one other thing I want to point out, he has a commitment to lifelong learning. So 10 years after being here, he did this program for medical informatics at Oregon Health Sciences University, recognizing how important informatics is in our modern healthcare. So since here, numerous roles in quality and processes of care, and he's held these roles both here and nationally. So nationally, he's part of the National Committee for Quality Assurance. So if you think about something important about what we do, I think quality assurance is something that we really want to make sure is driving the boat correctly. And then super productive as a researcher, greater than 140 articles, funding from the NIH. It's like alphabet soup when you deal with these things, but PCORI, AHRQ, and also some from industry. So with that, in 2020, he became a professor with tenure here. And I wanted to point out one other thing. Besides, we share a big overlap in hypertension and really wanting to get good blood pressure control. But besides that, in November of 2024, he ran a journal club, which was about medical management versus dialysis for patients with advanced kidney failure. So I'm excited to think that you might be pursuing something like that, and maybe some of us in the room will also be working with you on that as well. But today he's talking about using tech and teams in the diagnosis and management of hypertension. So think about this, with remote monitoring, with wearable devices, with the EHR and its ever development, we're at a really exciting time in medicine about how we deliver care and the care processes and how we can manage all this data that we have. So I'm really excited, and let's give Dr. Persell a warm, heartfelt welcome as he introduces us to this new frontier.
All right, thank you for that awesome introduction. And I didn't remember some of those things about myself, I think. Okay, so a couple things for disclosures. The most important is that I do get research funding from Omron Healthcare, and I'm going to be talking about some of that work today. And as you mentioned, I work for no money for the NCQA on one of their committees that brings you the HEDIS measure for high blood pressure, among other things. Okay, so I'm going to focus on limitations of in-office blood pressure measurements, the rationale for why we should systematically and properly record out-of-office blood pressure measurements for both diagnosis and treatment, and then talk about the range of options for delivering technology and team-supported care that's been done, and think a bit about what we might do, what our experience has been, and how can we put this into practice. And I'll share some of the experiences that we've had in Northwestern medicine doing some of this. So, sadly, even though we started to develop fairly good evidence about tight blood pressure control about a decade ago, it was the same time that we saw national trends in hypertension control start to deteriorate. And the control to the level of less than 130/80 is really abysmal in the NHANES data. And then even on over here, look, see, I can point like that. That works, right? Here, even more studies coming out emphasizing the benefits of tight control of high blood pressure. Some nuances there, but we're not seeing this evidence turn into practice. So, I think for me, really reaping the fruits of the benefits of tight control make it ever more crucial to know what the blood pressure really is. Are we over-treating? Are we under-treating? Is there a wide variation? And I'm going to argue that office blood pressure just doesn't cut it at all for this. Some of these things we could fix to some degree, although we don't. And then there are others that we really can't. Is the volume good in the back, by the way? All right, so in the office, do we position the patient properly? We can stop using the exam table, we can use a chair, we can support the arm. Do we rest the patient for 5 minutes? We don't. We try to do this in general medicine as a QI project. We increase the wait time from, I think, 60 seconds to 90 seconds. But we don't take standardized resting blood pressures in the office, and our schedule is not very conducive of this. We collect data, but can't easily distinguish data collected in the setting of acute illness from data when someone's stable. And that can influence our interpretation of the blood pressure. I mean, that's also true at home, but it's a limitation of our clinic data because people tend to come in when they're sick. And then, we could use unattended office blood pressures that are automated to help mitigate white coat effect, which is really well described. But this is also seldom done. That's where you put somebody in a quiet, dark room with a machine that takes several measurements without anyone from the care team in the room with them. But I don't know of anywhere that we're doing this. I don't think you all are doing it in nephrology. But we really can't get around visit-to-visit variability. We can't get around the fact that people are not coming to the office very often, so we don't have much data. And and it takes time and energy to do these visits, both on the patient's behalf and ours. And so, this is really interesting data. This is about 500,000 patients, most of whom are actually not taking blood pressure medicine. Only about 20% are taking blood pressure medicine. And this is looking at the same person with 2 visits that are less than 90 days apart. And it's looking at about 7 million pairs of visits. And what does this tell us? It tells us that for most people who are not getting changes in therapy or whatnot, the average difference within a narrow time period from their one office visit to the next, the mean is about 11 millimeters of mercury systolic. And it's really all over the map. And to me, that says that I could easily add a full dose of a single antihypertensive medication, which might produce, an 8 or 10 millimeter mercury drop in systolic blood pressure. And there's a third chance that I won't even see it if I just roll the dice and I'm unlucky. If I'm making a half dose increase, what do I expect? I mean, I realistically expect in hypertension to lower the blood pressure 5 or 6 points. You might not see this at all. You might even see data that shows the opposite, and it's just because of the play of chance. So enormous variability, visit to visit, even in a narrow time window, and even in patients who most of them don't have hypertension. It's cold now, right? My blood pressure is higher at my office, my home office, which is the 3rd floor guest room in my house, which is very old and very drafty. And the older I get, the bigger the difference my blood pressure is between the winter and the summer. And the more we look at populations that are on antihypertensive therapy, the bigger the differences between the winter and the summer. I don't know how cold it is in my patients' houses, right? I don't know if they live in a place with an old apartment building with a super oversized boiler that's churning out, hot radiator heat, or they're generally chilly with a sweater at home. And we don't know that we could be having significant chunks of the year where people are either overtreated because we raise their blood pressure medicine when it's cold, or conversely, they're losing control at times when the ambient temperature is lower. So a bunch of reasons that having more frequent, properly done out of office blood pressures is going to be helpful. And then if we can actually get them done, we actually need people to give them to us in a way that we can use them. And I love my patients who are fluent in Excel and they sort by month and they take the average of every month. And that's about 3 or 4% of my patients. If you're lucky, you get this, or if you get this scanned and sent to my chart. Is this person's blood pressure less than 130/80? Yeah, say yes. Is it below 130/80? It's 131/70, and 64% of the blood pressures are over the target, but it's close. It's pretty good. But it's hard to manage this data in our brains. So, a lot of you may be familiar with some of these EHR tools that we have in Epic. I'll just refresh them briefly. You can, in any encounter, phone, office visit, telehealth, record patient-reported vitals. Those become visible in places like the synopsis view. We can use them for our performance measures to figure out who's poorly controlled. And we can use it to say, oh, this person is actually controlled, but maybe they have white coat hypertension, and that's why they always look like they're failing the measure. But now if I record this discreetly in Epic or have a team member do it, I can use that. This is my phone with the My NM app, which I made Mike Zielinski, my PCP, order the BP flow sheet for me. It's a little tedious to put the data in, but I can put the data in and then it's usable in my Epic record. And here's somebody who could have had a blood pressure flow sheet and see what the display looks like to us. But this is also a patient who's actually doing remote patient monitoring where they have a home cuff. It's got a cellular connection. It's integrated into our system. Every time they take a reading, it is shortly thereafter transmitted into Epic. So all those forms of data in our current system can be used to guide clinical care. And these are just a couple of my patients who I actually have been including in some of my RPM pilots. The first one is somebody who I took care of a long time. I actually presented at our hypertension system, and he is typically, it's very common for him to have a blood pressure of 150 or higher in the office. He was on treatment. There was a long back and forth about him up on medicine, down on medicine, would do home monitoring. Sometimes I would pay attention to the home monitoring. Sometimes I wouldn't ask about it. Sometimes I would seem to discard it. And he did actually have some hypotensive symptoms at times. And even though his office blood pressure was in the 140 to 150s range, his home blood pressure mean was 110, and sometimes it was lower. So you can see these sort of pink dots are systolic blood pressure readings taken at home. How much more data is there here? Much more. And then about here, I halved his ACE inhibitor, and there's a slight increase, but still quite low. And then here he is on no medicine with a blood pressure of 129/79. I might increase it if it goes a little higher, but much more reliable data from this patient with this number of readings instead of these variable and infrequent office readings. And then the other thing is, this doesn't happen, I find, that often. And probably the reason it doesn't happen that often is because we don't give remote monitors to people whose blood pressure is controlled. But occasionally there'll be people who are controlled in the office, and we read about mass hypertension, but do we actually see it? And here is somebody I actually saw it. So he was having office blood pressures about 131/61. I think he would smoke less. He was smoking all the time at home. I don't know whether it was my relaxing demeanor or what, but he was running about 10 millimeters of mercury higher at home. And then when I graph these out, with in my synopsis view in Epic, I can see that his home readings are really running above the line for his compared to his office readings. But do we act like it's frequent? Do we know that it's there and we're not seeing it? And you see this when you do ambulatory monitoring too, that there are people who
I think exactly like Dr. Persell said, when their blood pressure was 10 clinic, I'm not thinking about it. If I saw they had an echo that had LVH or EKG that showed LVH, I might think about it to do it. But often when my busy clinic visit, am I checking that blood pressure, seeing it's normal, reviewing at that time, those
because right now it's not. Yeah, and the thing is, can we systematically test high-risk patients, or even all, I would actually argue all patients where we're really not sure what the blood pressure is? Because are you going to say, well, their LVH is due to all those years that before they saw me that they had uncontrolled blood pressure? And we don't hunt for it, right? And all right, so I'm going to acknowledge the benefits of ambulatory 24-hour blood pressure monitoring because I think it's important, but I'm also going to tell you why I think that it's not going to play a huge role still. It's really well tied to clinical outcomes and epidemiologic studies. It's really the way to get isolated or not nocturnal hypertension and non-dipping, and it's standardized procedure, but it's costly. It's not always super available, and it's hard to use over and over again when you're making changes to treatment. And it disrupts sleep. I wore one once, and I think I ripped it off at like 3 o'clock because it's waking you from sleep every 20 to 30 minutes, right? So home blood pressure monitoring, it's really well correlated with ambulatory 24-hour blood pressure monitoring. If you collect enough information, it's low cost, you can keep doing it. It will miss nocturnal hypertension. It's dependent on technique. Patients can do it wrong, and we have to continually be reinforcing how we want them to do it. It's like, please don't do it after exercise. I don't know what to do with that number. And there are also a lot of bad monitors out there. And just to quickly review how an oscillometric blood pressure monitor works, right? When we take our blood pressure, we feel the throbbing in the middle of the range, and it starts sort of slow and it dissipates. And what these monitors are doing is they're sensing that pulsation, and they're getting a curve of it going up in magnitude and then down in magnitude. And then they're applying an algorithm and saying, I think the end and the beginning of these 2 points are A and B, and that's the systolic and diastolic blood pressure. And how good the sensor is and how good the algorithm is is all proprietary and varies from one to the next. And some are not so good. So, I would encourage people to use validatebp.org, which really is requiring sites to monitors to be listed to actually have data that they're used and validated with, and they'll tell you the standard that they use to validate it. All right. So just getting people to do home blood pressure monitoring, not only does it give us better data for diagnosis and treatment, but it also probably improves blood pressure. I'm going to talk about that. I'm going to talk about patient-facing supports, particularly digital ones, and I'll tell you an interesting story that where there's interest in using these, although they're often underwhelming if you look at the rigorous clinical effectiveness data, and then a variety of levels of healthcare linked supports. But we've known for some time that interventions that give people home monitoring and ask them to use that, in a meta-analysis that was now done 6 years ago, showed there's about a 3 over 1.5 millimeter mercury decline in the active intervention arm that encouraged home blood pressure monitoring compared to controls. So how can we get better than this, right? So it's better data, a little bit better control probably just by getting people to monitor, but what about an app? Right? How many people have patients who are using some kind of app with respect to their blood pressure? Any patients, right? Not a few. A lot of people have a logging app that like the data goes into an app from their device. But you can use this to do a variety of things. Apps can deliver education, they can deliver reminders, they can do a whole variety of things. They can coach you, they can count how many little gold stars you got for doing an activity. And so we did one of these trials actually for Omron, comparing a sort of a coaching app to just their regular tracking app. And these are several other pretty decent studies trying to say, can I improve over just home monitoring by giving some kind of digital technology? And the short answer was that having a control group really matters, right? Because in most groups, when you enroll a group of uncontrolled hypertensive patients, you see a decent drop just by putting them in a study and saying, I'm calling attention to your blood pressure. And even if you don't do anything to them, just because you pick them out because they were high. And remember, people's blood pressure 10 points different the next time you measure it. So if you're selecting people out who are high, some of them are really high, some of them are higher, some of them are actually lower. You need a control group. The only of these studies that showed a significant difference by applying a digital app to home monitoring was the Cario study, and it was only about 2.4 millimeters of mercury difference systolic, and that was done in Japan. And there was some health team connection. It wasn't completely divorced from the healthcare team. These other ones really didn't show significant differences. And this is a meta-analysis of these trials. And you see that, what do I see when I look at this? Like, I see a lot of really wide bars, kind of a tendency to show that there's some action on the intervention is better side, but not a lot of action. And they only came up with a negative 1.6 millimeter of mercury difference systolic in meta-analysis, very heterogeneous. So I think the jury is still out for whether we have the right app to give patients to use with their home monitoring to help guide them along. All right, so what about us? What about our teams? There's a lot better data for this, right? So here, here's Bev Green's EBP study from 2008 that was done in Group Health Puget Sound. And this was sort of 3 tiers, like usual care versus home monitoring with a web interface versus home monitoring and a pharmacist and like telehealth, basically before it's time to adjust and react to blood pressure medicines. Karen Margolis, who, full disclosure, also sits on the NCQA committee that does the hypertension measures, did the hyperlink trial published in 2013. Also team-led telemonitoring pharmacists, out of office titration. And here's some of the studies from Richard McManus in the UK, which use a variety of different methods. These are more powerful. These actually work. And even back in 2018 in this meta-analysis where I showed you the power of home blood pressure to lower your average blood pressure by systolic by about 3 points, team-based care is more like on average 7 millimeter of mercury reduction compared to controls. And physicians are almost good as their team members, but not quite. So as you go from this sector to this sector to this sector to this sector, you see increase. This is a meta-analysis from a couple of years ago showing that as you get more intense in your co-interventions, you get better systolic blood pressure differences between intervention and control groups. And those ones that I called out, the Margolis hyperlink study and the EBP study, really powerful effects. Just the EBP study in patients the subgroup that started out over 160 systolic, they had a 27 millimeter of mercury reduction. Now the control group had a 14 millimeter of mercury reduction. So again, need a control group, but really good effects with that high intensity, out of office monitoring with a care team with out of office titration. But there's not widespread adoption of this. How many of our patients are doing this? How do we take these successful interventions and sustain them? And how do we get the time, the staff, the financial model, and how do we deal with the data, right? And so, anybody remember this movie? So Bev Green's study was 2008, and it showed that in clinical practice, this model is highly effective, and there was more data that reinforced that finding. And in the real world in 2025, most places are not are still lost in the translation of this evidence into practice. And so how do we, as a community that cares about hypertension, make feasible, sustainable, equitable, and financially viable goals of this knowledge base and put it into our patients' practice? So, I'm going to talk a little bit about, the remote physiologic monitoring programs, which got CPT codes that are covered by CMS as of 2019 for the most part. I'm going to talk about telehealth. So right now, when I put these slides in, I didn't know whether there was going to be telehealth covered by Medicare. And right now there's telehealth is covered through March. And then Congress has to decide whether the telehealth that we've come to know and love through COVID stays or goes away or gets changed in somehow. So they just extended it 3 months. So we have to wait for Congress. Congress will be a little, I don't know what Congress is going to do in 3 months. I don't know what this group thinks about remote monitoring. So I think they have other things that they're going to try to do too. And then maybe pay for performance and public reporting and other incentive systems are another piece of leverage that we can use to get this done. You know, the codes, the setup is pretty, this is you know, not a lot of money. This is the code for getting them set up with the monitoring and the equipment. This is the monthly code for months where somebody uses it 16 days, although I did read that the AMA is pushing to get rid of that 16-day requirement in a month to get a charge for the data transmission. And then this is when a clinician with spends at least 20 minutes in a month reviewing data, supervising care changes, communicating with the patient, and there has to be some kind of real-time communication. So that means telehealth, a telephone call at minimum. And the telephone call does not have to be the physician. It could be a team member who's not an advanced clinician. So those are some codes that have a modest amount of reimbursement associated with them. We've tested this in 2 different pilots at 6 primary care clinics here over the last few years. In 2 of the clinics, we also ran lists of patients and had ambulatory care coordination nurses send lists to doctors, ask them to enroll their poorly controlled Medicare patients, and then facilitate the enrollment of those patients by reaching out directly to the patients. The other 4 clinics were just, it was at the discretion of the treating clinician if they wanted to order remote patient monitoring. We made it available to them. This was all Medicare patients. We also plucked out propensity score matched comparison group to try to do an observational study comparing the patients who were prescribed RPM compared to very similar patients who are not prescribed RPM. This is the table 1 for the 2 different groups. So it's 288 RPM prescribed patients in 6 NM practices and 4 times as many controls. You can see that the office blood pressures are only about 143/77. And the mean, this is a mean age of about 74. And what we see is that the rate of achieving the last blood pressure, the most recent blood pressure less than 140/90 quickly goes up in patients prescribed RPM. We're using RPM in the definition of this measure. We're getting more measurements, right? So it's interesting. What we tend to see is that of these folks getting this RPM, there's more white coat than masked, and the people who have white coat immediately meet the measure because their blood pressure drops because they're actually lower at home. Then we sort of see a downward trend over the next 6 to 9 months in the trajectory of the blood pressure on average, with a lot of individual variation. But all in all, we're seeing a downward trend in systolic blood pressures. We're seeing more touch points. We're seeing more telehealth or in-person encounters in the group getting RPM compared to the matched controls. We're seeing more patient portal notes, and we're almost seeing more phone encounters, but not quite. You know, the way we first looked at medication was we wanted to say, like, what's the net change in your antihypertensive medication? So we counted increases or additions in the positive column, and we counted dose reductions and discontinuations in the negative column. And we saw that there was really no difference in the spread of dose increases or decreases net between RPM prescribed and matched control. So we were scratching our heads, and like, this wasn't obvious to us. We also saw that the number of people at a net hypertension increase was definitely not any higher in the RPM prescribed group. So then actually I should say Calvin Winkler's now at MS2. He was in MS1 when he first started working on his AOSC project on this. When we look at the time to the first change in blood pressure medicine, it's faster with RPM. So the average person had their first change by 148 days in the RPM group and 222 days. So first of all, this is like a huge amount of inertia, right? Because it shouldn't take this long to make a blood pressure medication change in a largely uncontrolled cohort. And there were more changes in the RPM cohort. And it seems that, there are more changes in the direction you'd expect. So if you look at net increases and like there's people getting reductions who are overtreated, right? There are people with really severe who have home hypotension because they have white coat effect and they're overtreated, and they're getting reductions. So we're looking now more at like the actual breakdown in response to the observed blood pressures. We're seeing more increases in the group that you'd expect and more decreases in the group that look like they're already controlled at home. We also showed that there was more powerful effects in the groups that got care coordination. So when we looked, the magnitude of the getting to the control level of 140/90 was definitely greater in the over time, in all the time points, in the subgroup that was getting care coordination. So that sort of goes along with, if you have more co-intervention, you get bigger effects. Now, not many docs enrolled patients. The percentages when left to their own devices was only a couple percent. But people wanted this. When we asked them for feedback, they said they wanted to be widely available, but they also wanted staff members to take care of it. And they really never used the clinician billing code, even though we set them up to do it and we gave them a way in Epic to document it and we taught them how to do it. They didn't do it. And they also keep worrying about, what do I do about all that data that comes in and how am I responsible for that? Am I responsible for it? So, two groups have published widely about non-controlled studies in real life that really try to bring this to scale with the computerized population management, outreach workers, community health workers, tracking patients, pharmacists titrating, teams, and like active treatment. MGH Brigham and Ochsner in Louisiana. This is the initial Brigham data. It a little bit belies, it actually reinforces what we found, which is they enrolled, this is 1,400 patients whose office blood pressure was 165. But when they got them doing home monitoring, their first week home blood pressure was 140, right? So a lot of people are getting into this because they have wickedly bad office blood pressures, or they have severe white coat effect. And over time, they see the population of patients who stick with it get quite good drops in their blood pressure. But only a subgroup of people stay in it. And it's a little bit hard to know because, again, every time you enroll poorly controlled hypertensive patients, you see a big drop. So this looks promising, but again, it means that you have to say that office blood pressure was really, really suspect, and only a subgroup of people follow through it to maintenance. And so here that goes from about 1/3, maybe a little more than 1/3 of patients get through to the maintenance phase of this program. And this is a study they looked at, sort of looking at their work during the pandemic, and showing that they really did were able to do this type of work during the pandemic and get similar results to what they got before the pandemic. Now, the Ochsner group published data that looks really dramatic. They actually did another propensity score study where they matched patients to controls, and they enrolled. I think now they say they have several years ago they had over 3,000 patients doing this, but actively sending them a machine, giving them education, having team members calling to do coaching, and then having in between visit medication titration. And a lot more touches and a lot more blood pressures in the groups that's doing this, right? So that this is 100 blood pressures recorded compared to the control group that has a handful of office blood pressures, and a lot more clinical touches. I don't know how they touch people 130 times. I think some of their touches probably count as like automated messages or something else, but much more contact. Improve medication adherence a little bit, and better blood pressure control levels. So again, all those take them with a grain of salt. We don't have a control group, and so there's some limitations there. But, so can we make this work financially? I think that if we get to the point where we can continue to do routine telehealth visits, telehealth is a visit, and we can use our, regular scheduled telehealth visits to do this, but we just have to be deliberate about it. But it could be value neutral, provided we can pay for the data coming in, which may continue to be covered and may be covered by more payers. Patients who don't have supplemental insurance under Medicare do have that 20% copay or coinsurance that they have to pay. But I think that if we get an extension of routine telehealth beyond March, that's a viable option for building systems where people proactively manage hypertension and get paid like they do in the office to do it. I think that we could get better at using smart teams to use that RPM clinician management code, where somebody supervises and looks at a lot of data and makes changes, and then the care member working at the top of their license who's needed to convey that on the telephone and do coaching can do it. Probably not the physician, probably not even the APP, maybe a nurse, maybe somebody else. That could potentially turn into a viable, payment structure. And the other thing is whether, there's enough skin in the game in contracts that have risk or that have rewards based on the performance of this, and whether it also and whether we believe it translates into health outcomes that actually, if we're in a shared savings program for these patients. So I was talking to our new VP CMO for population health, Dr. Amish Desai, and there's a really cool app that does a lot of behavioral science informed coaching around blood pressure and gamifies it and makes rewards and does all these things that we know from behavioral science that some people really like. It's like, I lost the Wordle today, so I was really kind of disappointed that I lost my streak. But there are psychologies to how you can do this. Again, apps, we don't really know how well they work unless you do an RCT. But there's interest in working with a vendor doing this because it seems so promising, and there is potentially some financial skin in the game for the health system to do better, both on the metric, but also whether patients actually stay out of the hospital. So I think that there's potentially a confluence of forces leading to us who've always wanted to be, who have read these papers, 10 years ago. Wait, no, now it's almost 20 years ago, who are interested in doing things like that then, and now potentially we can do it now. All right, Dr. Paparello and I are working on a project where we are testing our own version of an app, but it comes through Epic. And so we've enrolled 70 patients in an Omron-sponsored pilot to give patients RPM, and the RPM is connected to our IT systems algorithmic decision support that we have built with the IT group that basically does a couple things. It says, can you check your blood pressure more because I don't have enough blood pressures to tell you whether your blood pressure is controlled. It says your blood pressure is controlled, good job. And then it bothers you less often. And then it bothers you if you haven't done it for a long time. And then it says, I think your blood pressure is above your goal. And then the clinician, as you can with the BP flow sheet, can change the goal. So if 130/80 is too low, you can change it to 140. And it sends patients messages. And we've done this almost for 9 months now with 70 patients. And the mean age is 66. The office blood pressures were 143/79 on average. Interesting, when we got people doing RPM, about a third of them had really significant white coat hypertension and controlled home blood pressure. So that group, that 22 patients had an early mean home blood pressure of 121/73. And after 6 months, their home blood pressures have changed not at all. But the group that was above 130 had a mean blood pressure of 150/88, and their blood pressures in 6 months of doing this have come down 17 points systolic. The average patient's gotten about 9 messages and read 85% of them. And we are trying to get an NIH study to do this at scale. So, I think this is the ideal state I think we're working for. Can we get, data-driven, population at risk focused interventions that get people doing home monitoring? They probably have some level of support that's automated that does not require a human being. We have data that we can use in our system to know whether people are meeting our objectives. And then a limited number of high priority circumstances go to a team that does what it needs to do, but largely ignores large volumes of data that are not going to be clinically actionable. And also probably puts some responsibility on the patient to follow up when they're getting really bad readings. And I think that it's shared responsibility, because right now our patients who have a home monitor can get a blood pressure of 195 over 110 as much as they want, and we don't know about it, and we just say, oh, I don't have to know about it. It's not flowing into my EHR, so I'm not nervous about it. I think that there's something, we need to come to we can't throw out the good with the bad, and we have to say, we're going to all take responsibility for this. We're going to tell patients good advice about how to manage their blood pressure under different circumstances, but we're going to figure out how to connect this home blood pressure to a smart team-based structure that's probably supported with technology to give patients good advice in a timely way, give them the treatment they need, avoid over-treatment, and lead to better health outcomes. I think that's my last slide.
Thank you all for your attention.
Thanks.
Thanks, Dr. Persell.
Thank you.